Welcome, everybody. This is a special grand rounds. It's kind of funny that I thought that you kind of get a lectureship named after you when you die or when you retire. And as far as I know, I haven't done either yet. But it is obviously incredibly generous of Mary and Dan Rue to have started this lectureship, and so it's really exciting. And when thinking about who would be the inaugural lecturer for this, there was only one choice. So everybody knows who Louis Bigliani is, but I'll just share a couple of thoughts about Dr. Bigliani. In 1993, I'm a fourth-year resident from Tufts, and I come for my interview, and I go to Ashley Pavilion 245, and sitting there is Teresa and Trudy and Yannette and everyone else, and they have one office, and that's where everybody sat. And I always like to joke that if you knew Louis was having a really, really top-notch, like confidential conversation, both of his hands had to go over the phone. That was like really confidential. There was no privacy. It was unbelievable. That's where the world's most famous shoulder surgeon was doing business. But it actually said a lot about Louis because, for all his accolades, president of AOA, president of ASES, first president of the PO here at Columbia, the 9th chairman in the history of this storied program. The thing that's always separated Louis is his humanity and the interpersonal part of who he was, and how he always viewed his residents and fellows and the people that he worked with. Why do people who worked with him stay for 30 years? Because of the loyalty that he displayed to them. And that was the part that struck me then as a fourth-year resident in 1993, 26 years ago. So it's pretty amazing for me to be standing here today. And in thinking about this lectureship and what we wanted to do, I thought it would be really perfect for Louis to be the first inaugural lecturer. I found a quote that kind of, I think, says it all, and it is that leaders instill in their people a hope for success and a belief in themselves. Positive leaders empower people to accomplish their goals. And many people in this room are the direct beneficiaries of having a leader like Louis. We have over 20 of our former alumni who have all come from around the area. Mark Radowski flew in from Pittsburgh last night. It's pretty special. And lots of family and friends here to really share in their love and appreciation for what Dr. Bigliani has meant to them in their own lives. And so without further ado, I'd love to announce the first lecturer in this lectureship series, Dr. Louis Bigliani.
Thank you. Well, it's always fun to get back into the pit. I first came here in 1971. It was a little more intimidating then. There were walls and up, but it's fun to be back, so it's great. Thank you, Bill, and I want to thank Mary and Dan Rue for making this happen, and thank Bill for choosing me as the inaugural lecturer. So, it's the William Levine Distinguished Lecture in Shoulder and Elbow Surgery, but first we have to take a trip. It's a long way from Fargo, North Dakota. Bill was actually born in Winnipeg, Manitoba, Canada, and the family, it's a cute picture, Bill. And then the family moved to Fargo, and this is Bill in the 70s. And here we see Bill when he graduated from Stanford with a degree of human biology. And quickly, he then went to Case Western Reserve for medical school, Tufts for residency, here for shoulder surgery fellowship, and then to Maryland for a sports medicine fellowship. So therefore, it was logical for Bill to be my first recruit when I became chairman to start a sports medicine program. He did that and elevated the care that the Columbia athletes get to the very best. It was a sea change, and it's been successful for him up and still today. So Columbia is lucky to have Bill as their physician. Bill is not only excelled at surgery, but he was also a passionate teacher and an advocate for the residents when he was residency director. So he really has had a great career. Then he went on to be chief of the shoulder service and then chairman of the department. But along the way, Bill met Jill convisor, and they got married, and she has the last word because she's the judge. So, and this is Jill's favorite picture, smiling family, Bill, Claire, Jill, Sonia. So that's it. Good job, Bill. So now we'll talk about the history of the shoulder surgery at this institution, and it's changed names so many times, I put them all down. But shoulder surgery actually started on the fracture service of the Presbyterian Hospital in 1935. The fracture service was the idea and brainchild of William Darrah. He was the dean from 1919 to 1930, but he also had a bigger dream, which was to build a university hospital here on this site. And he convinced his roommate from Yale, Edward Harkness, to deed 22 acres of land and millions of dollars for the beginning of building of the medical center, and it was finished in 1928, so started the fracture service. Clay Ray Murray, who we see here, was the assistant director, and Barbara Stimson, probably the first woman trauma surgeon, was one of the attendings, and she was known as a passionate teacher and a great surgeon. Shoulder surgery didn't start till Harrison McLaughlin came down in 1934 as a resident and then an attending in 1935. So I divided up the history of shoulder surgery here by the chiefs: Harrison McLaughlin, Charles Neer, myself, and Bill Levine. Here's a picture circa 1935 to 1940 of Harrison McLaughlin and Barbara Simpson making rounds at the Presbyterian Hospital. And here's a picture of Dr. Neer with Bill and myself. But besides being chiefs of service, we had a lot of great attendings doing some work which really entered into the picture, and we couldn't have done it without all these great attendings. The first shoulder clinic and service and fellowship started in 1977 when Craig Foster and I talked Dr. Neer into creating this. And we've trained over 87 North American fellows. In 1998, we formed the Center for Shoulder and Elbow Surgery and Sports Medicine when Bill came on board, because we had the Columbia teams, as I said. In 1998, we started the Columbia Shoulder Society biennial meeting. And then in 2018, because of some regulations by the Sports Society, we had to split the fellowships, one sports medicine and one shoulder. Our imprint on sports medicine has grown. We not only have Columbia University, but we also have the New York Yankees, the New York City Football Club, which is soccer, and when George Zambetti came on board, we got Fordham University, and T-Shaw Lynch now takes care of that. We also take care of numerous high schools, including North Bergen, which I took care of, and now Chris Ahmad still takes care of. Ira Wolf, I think he's here, was a big factor in us taking care of that team. Here's the Columbia Shoulder Society, which meets every 2 years. This was at the Breakers in 2013, and it's a venue for alumni to share information and also get to know each other. But it's more than that. It's a family, and the kids really like meeting each other every other year, and it just continues to grow and grow. It's a great tradition. 13 fellows have started their own fellowship, which is quite remarkable. Ted Blaine actually did it twice. And we've had over 50 international fellows from 15 countries, and it's quite an array of different countries. It's unbelievable. Sorry you can't see this picture a little bit better, but the pixels wouldn't allow it. We also had an impact, this service, on the starting of the American Shoulder and Elbow Surgeons. Here you see Dr. Neer, the founding member, myself, Keith Watson, Tom Norris were fellows and residents. Tom and Bob Neviser were residents here. Hiro Fukuda came from Japan for a year. Pat Murnahan and Rich Hawkins from Canada spent time here as fellows. And other people who came to visit, Russ Warren, Charlie Rockwood, Bob Cofield, Rick Masson, all had come to see Dr. Neer. So we've had a tremendous impact on that society. Also, we've had 10 of the 38 presidents, past, present, and future, starting with Dr. Neer in currently Bill Levine, and then Javier Duralde will be president in 2021 and 2022. Also, we had a huge effect on the Journal of Shoulder and Elbow Surgery. Dr. Neal was the founding chairman of the board, and then I was chairman of the board in 2002 to 2005. Also, internationally, three of the five chairmen of the board of International Board of Shoulder and Surgery have trained at this institution. Dr. Neal was a founding member. I was chairman for 6 years, and Osvaldo Lek from Brazil is the current chairman. What that organization does is it oversees the International Congress of Shoulder and Elbow Surgery, which has been in existence for 39 years, and it's been to 6 continents, 13 countries, and 14 meetings. So it's truly a global organization. The last meeting was in Buenos Aires, Argentina, where they had close to 2,000 people attend. So let's get back to our service. This is the fracture service about between 1950 and 1952. It was a very tight-knit, loyal service. However, the photographer forgot to say cheese to this group because nobody was smiling. We'd see Harrison McLaughlin, the chief, Charles Neer, Fred Smith, the elbow surgeon, Dr. Garcia, who became chairman, supposedly was during the service in 1952, so he must have been a resident here, so I can't figure out what date this was. Sonny Gaston, who we'll talk about later, was an attending also. We'll start with Harrison McLaughlin and his accomplishments. One of the first things he did was canvass the literature for ways of fixing the rotator cuff. And then he came out with his way, which was to approximate the cuff when you could after mobilization and then do transosseous sutures. He came out and he was an advocate of lateral acromonectomy, which we'll see really wasn't quite the right operation. But he did lay down principles that we still use today, such as a smooth acromial surface, tension-free apposition, continuity of the cuff mechanism. And that goes today, whether you do it open or arthroscopically, it still stands. He also devised the McLaughlin procedure, which was for posterior fracture dislocation. What you did was take the, this was a chronic injury, so there was a big defect in the head. You remove the subscapularis and put it into the defect. It is still being done today. He also had a big effect on anterior instability. You can see here that some of his descriptions of the morbid pathology are what we still consider today. His article in the Journal of Surgery, The Morbid Anatomy of Anterior Dislocation, is a must-read for everyone. So he also, on the larger group of patients, said that 96% of people that dislocate their shoulder under 30 years of age redislocate. And 90% of people that have a dislocation after 30 do not redislocate. And that's been something that people have used as a marker for years. His crowning achievement, however, was the book Trauma, which sold 8,000 copies, double of any trauma book that existed at the time. What's really interesting, there were 13 contributors, 60 pages on the shoulder with fractures, rotator cuff, calcium, and dislocations was all written by McLaughlin, and the elbow 30 pages was all written by McLaughlin also. Neer and Smith did chapters. Neer did hip fractures and Smith did spine fractures, so it's kind of crazy. I searched the literature, and the only time that McLaughlin and Neer collaborated was in this paper in 1953 about displaced fracture dislocations where the head was dislocated. They based it on Codman's 4 anatomical pieces based on the epiphyseal lines, and because the fracture surface had such good records, they started back from 1929 to 1952. They had 20 instances of this fracture out of 1,700. The results of surgery were very poor, and there's a brief mention and a picture of a prosthesis that they were thinking about, and of course that was Neer. When Neer wrote his first paper on his series of humeral head replacement for fractures, McLaughlin wasn't on the paper, and he didn't mention it in the book Trauma. And Fred Smith wrote a book in 1954 on surgery of the elbow, and as I said, he did the spine. So they all respected each other, but they sort of kept in their separate lanes when they did academic work. Harrison McLaughlin, though, was really a great surgeon, and he was, as a surgeon, he had few peers. His knowledge of morbid anatomy, his inventiveness and resourcefulness, and his technical surgical skills were applied to his basic philosophy when operating. A master surgeon respected by his colleagues, a teacher revered by his students, a gentleman loved by all. He certainly was something else. It was a great start to our history of shoulder surgery. This paper by Sonny Gaston, given at alumni in 1977, is a must-read for everybody. The Other Side of the Family, the history of the fracture service at the Presbyterian Hospital. We think of ourselves as NYOH, but the fracture service here had some pretty powerful people. Neer continued his work. We'll talk about him on proximal humeral fractures, and he developed from that paper in the years to 1970 when he published a two-part article back-to-back. The first paper was on the classification of these fractures, and the second was the various operations needed to take care of these fractures. It was seminal work. He also developed the first workable shoulder prosthesis in the world. He redesigned the fracture prosthesis to a more of a reconstructive prosthesis and chose a high-density polyethylene glenoid. Before this, treatment of osteoarthritis of the shoulder was fusion, and now fusion is never done for this, so it was a great development. He also got back into acromial surgery, and as I said, McLaughlin was a proponent of the lateral acromonectomy and a saber approach cut to the shoulder. Some of these other people had more radical operations. This sent Neer back to the cadaver lab, and he made the determination that impingement actually occurs on the anterolateral portion of the acromion and devised an operation, anterior acromioplasty, to treat the impingement syndrome. Interestingly enough, he had 11 patients with lateral acromonectomy. It's interesting to note that the patients in this series were older, and in his second paper on impingement, Neer tried to say that impingement was a factor in sports in younger people, and it really isn't. When I looked at my series, it was almost identical in age. They were older people. He also, in 1981, wrote a paper on the disadvantages of radical acromonectomy. And here you can see a patient with his deltoid detached, no acromion, no clavicle, and a big deficit in a mainly useless arm. He then had a revolutionary approach to shoulder instability when he coined the term multidirectional instability of the shoulder. There was a lax capsule which allowed instability to go anteriorly, inferiorly, and posteriorly. He then devised the operation, the inferior capsule shift, to take care of this. The first series they did with Craig Foster had no Bankart lesions. It just had capsular laxity. There were, it was a totally different concept. I guess Neer is judged by what you write in the literature, and Kelly in the British JBJS in 2010 canvassed the orthopedic literature to find the top 100 quoted papers, and Neer had 5, more than any other individual in the world. Pretty amazing. 2 were on impingement, 1 was on fractures, 1 was on instability, and 1 was on joint replacement. So he actually is the father of modern day shoulder surgery, because quite simply, he created shoulder operations that worked. Before, they did not. So let's go to myself, and I apologize, I couldn't find my good slides on this, but I got interested in trapezius palsy because the shoulder's really disabled. It sags down, and these people have a lot of pain. I searched the literature, and what I found was the Dewar-Harris procedure, where you transfer the levator scapula laterally, and you have a sling to the spine to give medial stability. They both failed. So I presented this at Grand Rounds, and Bob Carroll said to me, why do the Eden-Lang procedure. And I said, well, what's that? He said, well, you also take the rhomboids, minor and major, and transfer them laterally. So I went to the literature and I found these two articles by Eden and Lang, and unfortunately they were in German and they didn't have any illustrations and not much about technique. So I sort of had to teach myself how to do this, and we reported in 1985 and then 21 patients in 96 with excellent results. Here's the levator scapula, rhomboid minor, rhomboid major. Sorry for the picture, but I also went and looked at acromial morphology because I wanted to see if the shape of the acromion had an effect on the rotator cuff. We looked at 224 cadaver shoulders. Average age was 76. 21% had rotator cuff tears, and the rotator cuff tears increased with the age of the cadavers. And then we actually did find 3 types of acromions: type 1 flat, type 2 curved, type 3 hooked. And most of the rotator cuff tears were with the hooked acromion. What I didn't do was differentiate whether it was the normal bone of the acromion or whether it was the coracoacromial, the spur that was in the coracoacromial ligament. And so then the next thing we did, fortunately, Greg Nicholson went out to Cleveland and looked at the Haymond-Todd osteological collection, and we found that over 50 years of age, 30% of the cadavers, of the bones, had this spur formation, which is exactly the insertion of the coracoacromial ligament. We then tried to see the effect of the different acromial shapes on the rotator cuff. To do this, we had to use a procedure called stereophotogammetry. It's where you put into the computer a digitation to map out all the parts of the surfaces of the acromion and the rotator cuff so that you can look at contact patterns and proximity. This is a hard work, and it's time consuming, and it's just tough to do. So we needed a Columbia engineering student to help us, and we had just the person. This is engineering student Chris Ahmad, which was a taste of what was to come in the future. And what we did find was that the type 3 acromion had more contact than the other 2 types. We also, with Ted Blaine taking this lead, looked at inflammatory mediators in the subacromial bursa, and we found that quite a few existed. Young-Soo Kim, a fellow from Korea, also helped with this, and Ted, I think, had at least 4 or 5 grants when we worked this through. We also did some biomechanical research with Van Mao, and we looked at the tensile properties of the inferior glenohumeral ligament. Quite simply, what we did was we stretched it numerous times, and we found that the elasticity wasn't there and that it underwent strain, which is change in length over length. So every time somebody dislocates their shoulder, they deform the capsule. I also had an RO1 with Van Mao on osteoarthritis of the shoulder, and Evan Flatow also had a grant on injury to the rotator cuff tendon. Evan and myself then, with Zimmer, devised a new shoulder replacement that was based on stability, durability, and reproducibility. We wanted to have it perfectly instrumented so that even someone who did 1 or 2 a year would know what to do. Marlene knew the instrumentation better than I did. One of the features of this was a dual surface glenoid. The glenoids at the time were either constrained, semi-constrained, and they led to edge loading, or they were not constrained at all, and it led to areas of high stress. This device had a conforming central surface and a peripheral surface which was less conforming. We called it a peripheral mismatch. Probably not a good word to use for marketing, but it turned out to give increased motion and good stability. Just for the fun of it, we made Fortune magazine in 2011. They used our reverse prosthesis as a new development that would help baby boomers as they got older. So that was interesting. Now we'll talk a little bit about Bill. In the late 80s and early 90s, there was a feeling that you didn't have to do a glenoid replacement and hemiarthroplasty was superior to a total shoulder. Bill reported twice over a period of 14.8 years on a series that we had started in the 80s and showed that with time, results deteriorated in all the categories. It just goes to show if you follow something long enough, things get worse. Then Bill started to work with Helen Liu downtown on basic science of rotator cuff healing. This grant right here, the biphasic nanofiber scaffold for tendon and bone integration, received the best paper at the Orthopedic Research Society in 2011. So this was great work. Bill had to go out to Colorado to do sheep surgery, and this is the team that helped him do that as part of these many grants. Chris Ahmad, who we mentioned earlier, spearheaded our interest in computer simulation. Bill and I also worked at this, but it was really Chris's genius which led the whole research team to be able to create a 3D coordinate system based on the patient's anatomy through a CT scan, and then we were able to put the components into the computer. Zimmer allowed us to do that, so we could do an operation 1 or 2 days before the surgery and know where the pitfalls were. You could look at peg penetration to see whether you used a large, medium, or small glenoid. And also we were able to look at the amount of contact that we achieved and the stress on the component when we, with these different percentages of contact. So it was great work. He also looked at arthroscopic rotator cuff repair and found that the transosseous approach had more contact than the single anchor suture, which was a great development. We'll talk a little bit about elbow. When he was out at Curl and Job Clinic, he got interested in the elbow and the ulnar collateral ligament, and actually won the Frank Job Award in Excellence in Research with his paper concerning anatomical repair. He has kept up his work being the doctor of the Yankees and looking at throwing injuries and concepts of dynamic stability, and he still does this today. So a little bit about Charlie Jobin. One of his interests is in looking at the cause of glenoid loosening, and for this he used the critical shoulder angle, and the increase of the angle led to more loosening in the glenoid components, which is interesting. Furthermore, he developed a safe way with the use of Mimic software to look at post-op polyglenoid version using both X-rays and very low radiation, using the Mimic software and X-ray rather than a CAT scan to help with radiation. David Kovacevic has also been interested in inflammation of shoulder tears, and he has a KO8 grant, which is a starter grant for the National Institutes of Health. So I'm excited to see what his research will show. And finally, we're fortunate enough to have Steve Thomopoulos as the director of the Carroll Laboratories, and fortunately he has an interest in signaling pathways in tendinopathy, so that should dovetail very well with David's work. So in summary, from 1935 to 1929, we've had academic progress in improving patient care. We defined shoulder anatomy, developed shoulder procedures, studied results, clinical research, identified syndromes and conditions, created shoulder arthroplasty systems, and then basic science investigators with a collaboration between scientists and clinicians to obtain external funding. Thus, in 84 years, we have consistently made significant contributions and leaderships to shoulder surgery, and no other institution in the world has that tradition of history. Thank you. I'm happy to take some questions.
Well, Louis, since I went through a lot of this with you, is a fantastic rendition going back to our roots. And I remember lots of stories and scrubbing with Dr. Neer and with you doing your modification for the wing scapula and seeing all this stuff develop. So just a phenomenal journey, and I'm glad to have been part of it. And the NYOH tradition lives on and is being embellished.
Yep.
It's not just historical, it's living and it's real. And you make quite a mark on orthopedic surgery and on so many of us. So thank you very much.
Well, great. So I thought that too, that it humbled me to see what came before us, but it also encouraged me to see what we have now, and the future will be even brighter. So it was a fun project to do.
Louis, fantastic. Thanks for sharing. I think for the residents and for the young faculty who don't always know the history of where they are, these kinds of talks are critical for our history, and it's great to have it recorded. Thanks, Ross. Maybe you could share what it was like. And we talk about innovation all the time and disruptive innovation as the way we move forward to help patient care. So could you just share with us, you developed some new procedures, like you talked about the Eden Lang. Just tell us about a little bit more about that process of trying to do something new that didn't exist.
So I was in clinic, and I saw a couple patients who had acromioplasty for this problem, and they still had problems because the shoulder drooped and went down. And when I went to the literature, it was quite frustrating because I couldn't find anything that was really good. So I started drawing, and I drew out all the muscles, and I drew everything out. I thought I had the drawings, but I can't find them. And when I started out, it took me 4 to 5 hours to do the operation, and I had to transfuse the patients. The last one that I did was done in a little over an hour and was bloodless, just about. And I just learned a lot, and it was pretty, it was pretty not an easy process, but it took a while.
Well, you'll be happy to know that just coincidentally, I got an email on Monday from one of your original patients that you did a modified Eden Lang on. And he said that at the time, he did not have the diagnosis of FSH dystrophy, but subsequently found out that that's what he had.
Wow.
And I'll send you the email, I haven't shared it with you yet, but he was sending it to me to thank you because he thinks that that saved him for the next 2 decades. And that's not a commonly performed procedure. Many people, as you know, will recommend a fusion, a scapulothoracic fusion for FSH dystrophy. And he was wanting me to share with you and with the community that actually the modified Eden Lang, he felt saved him for 2.5 decades.
Wow. Yeah, I also got a letter from and an X-ray from Henry Traub, who was one of the first patients that I operated on in the clinic, and he had deformed shoulders. We had to put a special prosthesis in. We went in the back and ground it down, and he said he's worked for some company for 40 years. He had his hip operated on. He had his knees operated on. He thought his shoulder was one of the best operations he had. And you get notes like that from people, and it really makes a difference.
Dr. Bigliani, I want to thank you. Incredible talk. And I wanted to share with the group here that the impact you had on the world of shoulder surgery and the prosthesis that you developed with Dr. Plato has the most volume of shoulder implantations of any prosthesis. And the number of people you trained have impacted the way we all understand shoulder anatomy. And it's a testament to everyone who came today to celebrate this first lectureship. So thank you.
Well, thank you, everybody. That's great.
Can I get all the alumni who graced us with their presence to come down so we can get a picture with Dr. Bigliani, please? Oh, I'm sorry.
Yeah, I can't resist. When I was a resident, and probably still true today, the shoulder service was the most intimidating service. And the day of the week that was the worst was Friday because Friday was walk rounds. And it was all the shoulder service staff, physical therapists, fellows, and the residents. And it was the junior's job to present all the cases, mostly Dr. Bigliani's cases. So we had a locked shoulder dislocation posterior that was post-op after a shoulder arthroplasty. I presented the patient is doing extremely well and happy and ready for discharge. And he asked me what the non-arthroplasty options are in front of a large group of people on walk rounds. And I was thrilled because I knew the answer. It was the McLaughlin procedure. And I knew the paper and I was ready to tell him the number of patients and the success rates. And he didn't ask me any of that. He asked me something very simple. He said, "Who's Harrison McLaughlin?" And I didn't know. And that was the end of walk rounds. And his love for the history is enormous, as you know, and the history of our department is so deep and rich. It's amazing that you share it today. And I had the privilege of operating with you. Technically, rotator cuff surgery done by Dr. Bigliani was amazing. Every rotator cuff tear was different. Everyone had a different tear pattern that needed to be managed. And through open surgery and then transitioning to arthroscopic surgery, his skills were very amazing in the operating room. And then as a chairman and a leader, he had an ability to push people and almost break them, but not break them, so that they could be the best they could be. So I've had the privilege of experiencing that, and I know everybody else has too. Thank you so much.
You only pick on the strong because they'll bounce back.
All right, all the alumni, come on down.